Just for the record, because we're filming now, I'd be grateful if you could just say who you are and how you're working and all that.
I'm Shakila Thangaratinam. I'm a professor at Queen Mary University of London. I'm also a consultant obstetrician who's working at Barts Health NHS Trust. I led the development of the Royal College of Obstetrician and Gynecologists Green Top Guidelines on management of epilepsy in pregnancy, and I was also the project lead of NIHR HTA funded Empire trial looking at anti-epileptic drugs in pregnancy, but not valproate, other drugs apart from.
Right, well thank you, that's very clear. And I think you didn't actually provide us with any written evidence because we've already met you and had a word. And I'm not sure if you provide any COI, conflicts of interest. Did you?
No.
No. Well,
I do not have any conflict of interest.
Oh right, all right. So that's
I'm not aware of a form or anything. I don't recall any form being requested for signature.
No, we just asked individuals whether they would give a statement as to whether they had any conflicts.
No, I do not have any conflict
with the industry or any other body, regulatory body. Thank you.
Right, thank you very much indeed. So if I could just start then and ask you, we obviously have the pregnancy prevention plan now in place, and that's a step forward. But do you think that women really are aware of that? Are you seeing that actually taking place in your practice? Do women aware of the PPP? And since 2016, when you were involved, have you seen a change in practice?
My involvement in care of women with epilepsy is primarily from a research aspect rather than from a direct involvement as a clinician, because the clinical management of women in my trust is seen by my colleagues, not by myself. If you ask me based on my discussions with my colleagues, both general practitioners as well as my consultant colleagues, yes, there is an awareness amongst the healthcare professionals. Pretty much almost everybody who's involved in the care of women with epilepsy, particularly the reproductive age group, are aware because we've all received emails, the mandatory emails on the change. I think it's a bit early to comment on has it trickled into a change and increased awareness amongst pregnant women or women of reproductive age group, unless there is a specific exercise that's been ongoing, either a survey or some sort of communication. So I think I'll find it difficult to say if it's resulted in an increase in awareness amongst the pregnant women.
Right.
What about numbers of unplanned pregnancies?
Since last year.
Since 2016, when it was a voluntary program?
I don't have the figures with me now. I don't know.
Sense of that?
No. I think if you look at the other services like the sexual health services, it might be helpful to look at the number of mothers who are going for terminations with an indication that they are on valproate. I think that might be one way to find out if there's any change in the numbers who are coming through who are requesting to end the pregnancy.
So just thinking about your clinical practice and also your wider remit, can I ask you that we've heard about women who actually switch from valproate when they find that they're pregnant, and so they go on to another medication. And I wonder if you could tell us a little bit about that and the impact that might have happened, might have taken place in terms of the management of their epilepsy and their general health and well-being, and also the impact that might have had on the development of the fetus.
So there are 3 ways in which women end up being on valproate while they're pregnant. One, they've already been started on valproate as a child for epilepsy, and at some point in time they get transferred for their care from the pediatric services to the adult services. And that is one way in which there could be a mismatch or miscommunication the only person who is the strand throughout is the general practitioner. So I think to fall women, to prevent the fall of women through the gaps, because we need to switch them when they move from being a child to being a person who is now in the reproductive age group. That information needs to be contacted, need to be provided to the secondary care epilepsy specialists. So that's one. So they've been on it as a child, but then they've never been switched as an adult. The second one is they have been started on valproate for the first time while they are of the reproductive age group. And that happens when they have for some other indication. We don't know that they are actually planning pregnancy in the immediate or the long term. For those women, there needs to be an ongoing discussion with the general practitioner, hopefully with a yearly discussions they're now going to have. Are they going to have the contraception or are they going to continue the pregnancy? So again, it's the general practitioner who is the first point of call to alert us in secondary care. Look, this is the plan. This woman has now changed her mind. She wants to get pregnant. Can we change the drugs? The third scenario is they started on valproate for the first time when they're pregnant. I think that's a very, very rare scenario, that somebody who's never been on valproate has now been started to control the epilepsy. And I can only think, if the epilepsy cannot be controlled with any medication or any number of drugs, and this is the only option, but it's extremely rare for such a scenario to take place. So if you look at each one of them, when you switch them to other anti-epileptic drugs, and I'm only talking in the context of epilepsy, not of other indications for valproate, the main thing to look for is how effective are the other drugs. And often neurologists, and I'm not a neurologist, I'm not fully qualified to explain that, but often neurologists would want to switch them to a drug that's got an equal effectiveness in preventing the seizure. And sometimes one drug might not be enough. They might need to have them on more than one non-valproate drug. And again, that's a decision the neurologists have to take, because high doses of other drugs are not necessarily always safe. Do we need to keep them on a lower dose of valproate with a 5 milligram of folic acid to prevent any neural tube defects? Or are we going to put them on multiple drugs on high doses, which also could potentially be dangerous? And I think that's a discussion can only be held between the neurologist and the woman, taking into account how well the epilepsy is controlled with other drugs.
So for some women, probably the easiest access for advice is their GP. And I just wonder, you talked about the annual review of their medication and their health generally. What evidence do you have that that annual review does take place?
I think it has been mandated more now, the annual pregnancy prevention program. I'm not aware that this has been mandated for the general practitioners to do it on a yearly basis, with particularly with specific details asking about contraception. Since it is mandated, I'm hopeful that we will be able to have this discussion with the moms. Of course, it depends on the woman actually turning up to the clinic and having the discussion. And I think it would be good to have a further plan. What happens if someone says, I actually don't want to go on a pregnancy prevention program? Then the next discussion is, okay, if you're planning pregnancy, let's start you on 5 milligram of folic acid. That's a higher dose of folic acid than what is routinely provided, because that has a potential to prevent neural tube defects, one of the known abnormalities associated with valproate, as well as minimize some of the neurodevelopmental problems these babies may have in the future. And if the woman says, okay, I'm not so sure if I want to get pregnant, but neither do I want to have a contraceptive, then again there needs to be a mechanism in place for them to then talk to their neurologist, taking into account, this is where we are, what do you want to do? So I think the PPP, the Pregnancy Prevention Program, is the first step, but there needs to be some additional information for general practitioners on what to do in somebody who doesn't want to enter the PPP. On, are they going to get pregnant? How long are they going to wait? I think it will be helpful to have some more details on that.
Would a general practitioner seeking more information, would they go to your Green Top guideline? Would you be circulating that?
It is available, the Green Top guidelines, but it's mainly to do with pregnancy. It's to do with management of epilepsy in pregnancy. So for pre-conception counseling, it will be guidelines such as the NICE, which cover the general population. And I also think MHRA has now given out a lot of information on the discussions to be had with women on valproate who are considering contraception or to try to get pregnant. And that has been part of the communication which all general practitioners have received.
So I'm just thinking of the general population for a GP. If he has 2,000 patients, what percentage of women who have epilepsy and of a childbearing age would he have in his practice?
I think nationally we have around 27,000 women who are taking valproate.
Sorry, I've missed the figure.
Around 27 to 33,000 take valproate of the reproductive age group. And I think we estimate that around 350 to 400 might be getting pregnant on valproate every year.
Right. Thank you. And is there a follow-up on those women? Other than, I suppose it relies on the annual review with the GP.
If their epilepsy is well controlled, then I'm not a primary care practitioner, so it's a bit hard for me to understand what happens in primary care. So, but the only time I get in contact with them is when they get pregnant, and then they enter my specialty. So, how we do inform GPs, and that's through regular GP updates. So they have these annual or biannual training programs depending on the area, region they are in, on the need to refer these women, mothers, to us early as soon as they get pregnant. That's number one. And also to start them on, again, the folic acid even before they're planning pregnancy, 3 months pre-conception. So that's also very important. So these are things that are slightly outside our control, the periconceptional one. But a good preconceptional advice would prepare these women to start the either change, or if they can't change, at least to start them on 5 milligram of folic acid.
Thank you very much.
So those 400 or so women who do fall pregnant whilst taking valproate, do you know anything about the reasons why they fell pregnant? Is it because no one warned them, or is it because people did warn them but they took their own decision to continue with valproate anyway? Do we have any information about?
Yeah, I mean, no, to surprise to say, less than half of the pregnancies are planned, and that's looking at the general population. So it's very hard for us to. So all we can say is around 45 to 50% or even more of pregnancies can be unplanned. It's not that that's a conscious decision to say, okay, over the next 6 months, let me start thinking about falling pregnant.
And that would suggest that they weren't using contraceptives.
Yes, so that's the thing. So that's the reason why when they come and see the GP and they say, I'm not going to be on the PPP, the pregnancy prevention program, then there really needs to be a good discussion on, okay, what are your alternatives? And also talk about not all contraceptives are the same effectiveness. Also give advice on the contraceptives that are more effective and some that may not be as effective in preventing the pregnancy. So one reason why women could become pregnant on valproate is unintended pregnancy, just didn't expect it. So never took any contraceptive and therefore became pregnant. 2 is, despite being on contraceptive, maybe something happened, they had vomiting, they were throwing up, they forgot their pill. So there could be other reasons that resulted in the failure of a contraceptive. So these are women who didn't want to get pregnant, but unfortunately did become pregnant despite being on contraceptives. And there could be a third a group who consciously did make a decision, fully knowing they are on valproate, maybe they had a discussion with their neurologist who weighed the risks and benefits and decided that their control of epilepsy can only be achieved valproate and versus the risk to the baby, and still made a decision to become pregnant. And the last group did not have preconception counseling with a neurologist, was on valproate, knew about the risks, but still decided to get pregnant. I think that will be a very small number.
But is anyone capturing data on how many women fall into each of those different?
I'm not aware of, for those who are on valproate, the reasons why they become pregnant.
And do we know anything about how many of them have the baby and keep the baby, as opposed to terminate?
I don't have. But what we do know is in women who are on antibiotic drugs, up to 15% would spontaneously, there is data on that. The data shows that 15% would just stop the drugs themselves without having a discussion with the healthcare professional, because they are very worried about the baby. They may not necessarily always tell their healthcare provider for fear of being judged that they're not taking whatever they've been advised. And I think that is one thing we need to be aware of as clinicians. Yes, we tell moms about all of the risks of valproate, but we also don't want them to stop it, because it could be the only thing that's actually preventing them from having seizures. In fact, I think 2 of the 9 mothers who died in the last confidential inquiries, they did stop the valproate. I think we also need to be aware, for a very small minority, this could be the most effective way, and I think these discussions should be coming up in the preconception counselling.
When women do stop their medication, do they usually stop it pre-conception? Do they stop it when they find out they're pregnant? Do we have any feel for that?
Based on my own experience in the joint epilepsy clinic that I used to do, it's usually when they find that they're pregnant that they end up stopping, because it's just not something that they thought about earlier. But then once they get pregnant, you realize, oh my God, I'm on a drug that's going to harm my baby, and your first inclination is to stop whatever you think is harming your.
But I was just
child.
trying to work out, it's not a preconception planned thing necessarily.
I think if they are usually thinking that much through, then they usually would also have spoken to a healthcare professional. It's usually, I'm pregnant, okay, let me just stop the medications I'm on.
Can I just ask about the Green Top guidance? So when that came out in 2016, was there any formal guidance around before 2016?
There has not been any dedicated guideline targeting only pregnant women with epilepsy before that. In fact, there has not been any guidelines before or since, apart from UK's own guideline. There have been guidelines such as NICE and SIGN, the Scottish guidelines, which target all individuals with epilepsy. So there are sections for pregnant women, preconception, children, but not something dedicated on how do you manage someone with epilepsy in pregnancy, during labor, and postnatally. So that's the first one that we did.
And has awareness of the risks associated with taking valproate while pregnant amongst obstetricians and gynecologists, has awareness amongst the professionals increased, or do we not know?
I would expect it to be increased, particularly among so every time when a new guideline comes, all of us in the profession are aware of it. So just by the fact that a guideline, a Green Top guideline is something, is an important one that's going to have implications on our management. So the fact it's a Green Top guideline itself does impact on our practice. And again, trainees are very aware of these Green Top guidelines. It becomes part of their curriculum. In fact, it's part of their exam as well. So if they're not studying for clinical management, they usually study definitely for their exams. I don't know how many hospitals now have epilepsy management as part of their routine guidelines. So we have guidelines on management of diabetes, induction of labor and things. The last time we did the Empire trial, not all hospitals, or not even half of them, had guidelines for managing pregnant women with epilepsy, and that could be because no such guidelines with Green Top existed. So I don't know if it's translated into local guidelines, but definitely the national guidelines are applicable to all.
What about the appraisal processes? Should it be, is it or should it be incorporated in appraisal processes?
It should be part of their appraisal, particularly if they're managing pregnant women with epilepsy. Yes, it will be part of it.
It will be.
It will be.
Do you find it extraordinary that there was nothing prior to 2016 on the management of epilepsy in pregnancy? And epilepsy is not a rare disease, and the issues around sodium valproate have been with us for decades. So it's just quite extraordinary to think that there is nothing.
Yeah, I think I was also equally surprised, and I think it could be because obstetricians see women with epilepsy, or possibly have looked at it as if it's something in the realm of what neurologists deal with, because it's all medical condition. And the neurologist, when somebody will get pregnant, it's seen as a mainly an obstetric one. And then the midwives think this is not a low risk, but it's a high risk condition. Definitely, this is something what we observed while we set up the Empire trial. Was in some hospitals we had to actually introduce the teams to each other, the neurologists, obstetricians, to set up the trial. I think that could be one of the reasons. There are other conditions like diabetes in pregnancy, for example, where we have a really good working relationship between the diabetologists and obstetricians. But epilepsy is slightly rarer compared to diabetes. So I think the awareness has been a bit slow.
So how do you build the relationships? How do you get it to a position more like diabetes where there is a joined up frame?
So we made, one of the recommendations is that in the Green Top guidelines we said we recommend a joint obstetric neurology clinic to be in every unit that's looking after pregnant women with epilepsy. And I think it also does need support from NHS England and other bodies to promote this joint obstetric epilepsy clinic. And also neurologists and also the general practitioners to refer the women much early. We often find the referrals come around 20 weeks or later. So we need early referrals for us to have these discussions, do scans early, talk to women on what they want to do with the pregnancy.
But is there capacity within the system to have this kind of multidisciplinary approach?
I think it depends on the hospitals. So if there's a tertiary unit such as the Royal London Hospital, where I work, yes, we already have a joint clinic. In a district general hospital, it may be a different circumstance. But even there are neurologists and there are obstetricians. I think it's to have a mechanism to have them both bring them both together.
Do you need this multidisciplinary approach everywhere, or should there be centres that just focus on this rather than trying to make it happen everywhere?
In the last, again, confidential inquiries, more women died from epilepsy and pregnancy than preeclampsia, for which we are very good in managing. So I think the more efforts we make to bring together the neurologists, midwives, epilepsy specialist nurses, and obstetricians, I think the better we will be in improving outcomes for these women. So I think that definitely yes is a place. Or if they don't have the capacity, at least have a system in which they can actually refer to a closest tertiary unit for care of these women in pregnancy.
Just taking a step back for a minute from the guidance, this review is looking at 3 different elements, as Baroness Cambridge mentioned at the beginning. One of the themes that runs across all 3 is that it's about women who've raised concerns about what's happened to them and to their children. And what we've often been told as we've travelled around the country and met many hundreds of people affected is that they've been ignored, or worse, actually dismissed by the medical profession. Does that surprise you?
I think we as a medical profession, from my interactions with the neurologists and obstetricians, have been aware of the risks that valproate poses. This is, I wouldn't necessarily say the medical profession will be dismissal if somebody says, I have got concerns about valproate intake or the dose, because it has been recognized to be a drug that has got the potential to cause harm, to the high potential, in fact, to cause harm. So I can't really comment that the concerns will be dismissed, because that's not been my experience working with clinical colleagues, either neurologists, epilepsy specialists, or obstetricians.
I think in the case of valproate, it's concerns expressed after the birth of the child, as opposed to concerns about taking valproate. It's a woman noticing, or a family noticing, that there might be something wrong, and then battling to get support and treatment and diagnosis in the first place for what's wrong. And they've really struggled to do that.
I think it will be the neonatologist with whom they will be having a lot of these conversations with, because they have concerns about the baby. The first port of call is talking to the neurologist, the neonatologists, and then coming backwards and asking the obstetricians.
I just wonder whether it's symptomatic of a general problem within medicine, that there's a tendency not to believe the patient.
My own practice has been to address any concerns that the mom has, so much so to even bring them afterwards for a 6-week detailed chat about delivery of the baby. So I think it's very hard for me to overall say that it has been. I really. It's difficult that some of them do feel that way without the individual details of the individual case. I think it will be very hard for me to actually comment on that.
Okay, thank you.
You're a professor of maternal and perinatal health.
Yes.
Do you see mothers and babies who are affected by other teratogenetic agents, fetal alcohol, warfarin, immunosuppressives?
Many of them will be diagnosed if intrauterine. It will be done through the fetal medicine unit, who deals with malformations in the fetus. And if they're also coming to the epilepsy clinic, then yes, babies with anencephaly.
Have you done any work or research on other teratogenic agents other than valproate?
No, my focus has also been in epilepsy. My research has been on epilepsy and anti-epileptic drugs,
Yes.
not specifically on valproate or malformations. It's only in the context of my overall work.
Thank you.
What about the new generation of anti-epileptic drugs? So something like Keppra. We've got women who have now moved on to Keppra, and actually some who said we think we've got problems with that too, with babies that have been born.
Absolutely, I think that's it's very important. We actually know the effects of these drugs. So two things. One, we want to know the immediate effect of these drugs, physical manifestations. And that's why we need every single mom who is on antibiotic drugs to register themselves in the UK pregnancy registry. And then the next one is the long-term effects of these agents like Keppra. For example, we are planning to follow up the babies who are born in the Empire trial. So these babies are now 5 years of age, and they have been exposed to newer antibiotic drugs like Keppra, and it offers a good opportunity for us to study and actually compare. Okay, these are randomly allocated, so there's a group who are exposed to possibly higher dose of Keppra, whereas other to smaller doses.
So have you got any earlier results of findings from this?
We need to get the funding to follow up, but we have got consent from moms to follow the babies up. Because it's better to wait. I've been told by the neuropsychologist it's better to wait a bit longer to have some definitive answers on the effects of the neurodevelopment rather than trying to do it at an earlier age. But that's something definitely that's something that needs to be done. Not necessarily in trial context, but even in as part of routine practice, we need long-term safety data.
Well, because we don't want to repeat the sodium
Absolutely.
valproate story.
Yeah, definitely.
And I just ask you about the register, because at the moment the way it's set up and things, it only follows through to the baby sort of reach a 3-month stage, the UK Epilepsy and Pregnancy Register.
I don't, I'm not involved in that
So you've
follow-up
not
of the
used it,
registry.
you've not?
No, I have not used it, no. I mean, I asked moms to go on and enter their details. But I
Right.
think the team that's involved in it might be able to give you better answers on.
No, I was
on
just
where
wondering
they're
about
following
its
up.
usefulness, if that is indeed one of the parameters, that it stops at 3 months. It doesn't sound like it's giving you the sort of follow-through data that you want.
They may be able to contact mothers to do a long-term follow-up.
We can do that.
Yeah.
Thank you.
Yes, we heard this morning from another witness that really we should follow up to at least they go to school, these children go to school, because then other things you can decipher that have. Is there anything else you want to tell us?
No, I think we've covered everything. But please let me know if you need any information that I may not be able to provide you today,
Right.
and I can provide you by email if needed.
So
Thank you very much.
Just going to ask my team. Do any further questions?
I just wanted to, in your evidence, you said that going forward it would be useful to have a qualitative study on women's views of epilepsy and pregnancy and their risks and concerns. Is that sort of in progress, or is that?
As part of the Empire trial, Professor Elaine Denny, she's from Birmingham, their group has done qualitative work on the views of mothers with epilepsy in pregnancy and on taking anti-epileptic drugs. So that's actually out as a HTA report. It's published on their concerns about taking the anti-epileptic drugs. But these are not women who are on valproate. I can provide you with a copy
I
of
was about to say
report.
that predates this though, doesn't it? I wondered if things had changed since.
No, we haven't done any qualitative work since.
Okay.
Well, thank you so much for coming. I just want to say at the very beginning, you were talking about less than half of pregnancies are planned. I just want to say I was extremely surprised to find when I was pregnant, but actually delighted. But you're quite right. Thank you for all the information you've given us, but thank you particularly for all the work that you do for women. And I'm sure they, and certainly we are very grateful to you. Thank you.
Thank you for giving me the opportunity to come here today, and if it has been helpful.
Definitely. Thank you very much.
Thanks.
Thank you.